Yes, yes, Dr. Samatimba, we can start.
Okay. Thank you very much. I want to welcome all members here, ALASU members and beyond, to this webinar. I want to first thank Dr. Spire for making an effort to organize this. It's always good to be willing to share knowledge. The topic today is adenomyosis, management options, and fertility outcomes. Adenomyosis is such an enigma that most of us, when we leave school, talking about postgrad, we are not so sure what to do when we find patients with a disease. Usually the problems begin with diagnosis and spill into management. And even after management, we still have so many complications. So we thought as ALASU, this would be a very good opportunity for us to share with the little we have. And then I know Dr. Spire will introduce Dr. Rod and Professor Yamal to discuss most of these things. Dr. Spire, you have so many questions to answer in your presentations because, like I told you, this is such a big problem to our setting, especially at, when we have to begin with difficulties in making the diagnosis, the proper diagnosis of the disease. Most people understand the pathophysiology, but that's where it ends. Management becomes a problem. So hopefully, by the end of this presentation or this discussion, most of our questions that are lingering within the minds of gynecologists around and beyond are answered. This will be an interactive session, and hope your questions are, when you get a question, please put in your chat box. We shall read them out, and I know we shall discuss this and iron out most of the challenges. So I want to welcome Dr. Spire, who is the president of Association of Laparoscopic Surgeons of Uganda. I'm Dr. Samatimba Stephen, the treasurer of the association. Dr. Spire has been such a wonderful force for our drive in laparoscopy and beyond. He has helped so many people around the country and the neighboring countries, actually, with the team at Enrop Hospital. Dr. Spire, the floor is yours. Please first introduce our panelists. And because you're such big men, and then we continue with the discussion. Thank you very much.
Yeah, thank you very much, Dr. Samatimba, for that humble introduction. I want to, of course, take the opportunity to thank everyone that has taken time to come in for this very important webinar. Just like you said, adenomyosis, just like endometriosis, are really one of those issues that are quite perplexing and difficult to discuss. And in that spirit, I invited my very good friends, and I'm very happy to know that we have Professor Yamal Fiki. Professor Yamal Fiki is a very renowned and experienced MIS surgeon. He's a fertility consultant and is the head of a postgraduate degree program on reproductive medicine at Rabat, Morocco. Prof, we are very delighted to have you today. So that you throw in.
Very happy to be with you, Spire.
Yes.
Nice to meet colleagues from Africa. And I think it's a beginning of a very beautiful experience to share together.
Thank you very much. So, Prof, we share a platform on the Pan-African Endometriosis Society, where I also belong as the founder member. And he comes in here with a lot of experience with the treatment of infertility. And I'm sure by the end of today, he will have thrown quite a lot of light on the experience of adenomyosis and infertility. Also, allow me to introduce my other very good friend and my mentor, and this is Dr. Rod Rocha. Dr. Rod Rocha, we met in our membership in the World Endometriosis Association, and he was allocated to me as a mentor. He has been such a good mentor in the field of endometriosis and adenomyosis. Dr. Rod Rocha is a senior consultant, a senior gynecologist, and a surgeon. He's an MIS surgeon. He's a senior sonographer. He has particular interest in endometriosis and sonography. He's very good in ultrasound for both endometriosis and fertility. He has a fellowship at the Acute Gynecological Service in advanced endometriosis, ultrasound, and laparoscopy from the Nepean Hospital University of Sydney. And he's also the assistant editor of Human Reproduction Update. Dr. Rod Rocha, I'm very excited to have you here today. I'm sure you will pop in here and there with a lot of your vast experience. Thanks very much for coming.
Thank you, Spire. I think it's a huge honor to be part of this great community that we have around the world. And I've told you this before, and I think that you guys are doing a very, very good job on trying to get much more efficiency in the treatments in your scenarios, and trying to advance in science, and especially in this field of adenomyosis, which is a huge problem for you. And I hope that we can advance in the discussions and bring the best for our patients. Thank you so much for the invitation.
Thank you, Dr. Rod. Dr. Rod comes from Brazil all the way. How is Brazil?
Well, politically speaking and economically, maybe things are not doing so well, but we have been surviving this kind of stuff for decades now, and I think we are tough people. I think we will endure with God help us.
All right, thank you very much. Nice to see you once again. Allow me to share my slides, and I begin with my presentation. It will be a mixed presentation looking at the adenomyosis and its impact on fertility. We shall be discussing a number of things, especially the impact of adenomyosis on infertility. We shall also drill into these are my objectives. By the end of today, we shall know the mechanisms of adenomyosis, associated infertility. We need to critically look at the diagnostic modalities, especially the sonographic ones, and also to review the treatment options for adenomyosis associated infertility, including uterine preservation surgeries. Of course, we all know that adenomyosis is the appearance of endometrial tissue and stroma within the myometrium of the uterus. And sometimes it has been classified as in several ways. The common is the classification of the extent, especially diffuse or focal. For some reason, we have more adenomyosis posteriorly, and this is also emphasized by this study. The grading system of adenomyosis looks at the depth, actual severity, especially in terms of depth. And this classifies adenomyosis into three: the deep, intermediate, it is of particular interest to note here that the common symptoms of adenomyosis, especially menorrhagia and dysmenorrhea, are more common in the deep type of adenomyosis than the intermediate type. So if you see a patient having any of these symptoms, most of the time they have the deep type of adenomyosis. However, superficial adeno was not really associated with any of those symptoms. The question is, who is at risk of adenomyosis? Several studies have been done, and I looked at this one in particular, which emphasized the role of hyperestrogenism. And it looked at women who have allomenac less than 10 years, women who have short menstrual cycles, especially less than 24 days, oral contraceptive use, interestingly. Some of us use it in the treatment of the same, and high BMI, especially more than 30. Women who have bared more than 2 children are more likely to have adenomyosis. Women with history of pregnancy termination, and then prior uterine surgery. And I think this is attributed to the risk of injury and repair. The pathogenesis of adenomyosis usually stands on 2 legs. On one arm, you have local hyperestrogenism, and on the other hand, you have tissue injury and repair. This diagram looks at the pathophysiology of adeno. We can see that it all starts with increased estrogen levels, and this causes increased uterine peristalsis, especially the corpus of the uterus. And then you have a combination of injury and repair, especially at the subendometrial area. It is particularly clear in this study that there was a noticeable increase in the mediators of acute inflammation, especially the beta-catechin, interleukin-6, and the macrophages. And this basically explains that adeno is really an inflammatory disease. And there was downregulation of these mediators of decidualization and implantation. So it is really a mixture of a number of things. But what comes out here is that adeno is usually an inflammatory disease, and it affects implantation and decidualization. And perhaps that will explain why it has many effects on infertility. The clinical presentation, usually most of the women will come with dysmenorrhea, chronic pelvic pain, dyspareunia, infertility, and sometimes there's a risk of a miscarriage. But particularly, I want you to note that 33% of women in this study are presented as asymptomatic. I want to suggest this triad for you to look out for adenomyosis, especially women who present with dysmenorrhea, menstrual bleeding, or heavy menstrual bleeding, and infertility. And to be honest, the incidence of adenomyosis, according to this study, in patients with dysmenorrhea or with these symptoms was as high as 50%. Most of the women, especially 30% of them, will present with a tender and enlarged uterus. And commonly for focal adenomyosis, you realize that you have lesions on these sonographic images, and this is what you would see in the diffuse picture. Quickly, to remind ourselves that in the description of adenomyosis, there are a number of lesions sonographically you have to look out for, and these are both direct and indirect. And here we can see that most women you would assess for adenomyosis would have a discrepancy on the size of the uterus. Generally, they have a globular enlarged uterus, and they might be asymmetry of the anterior and posterior wall. Then you have the myometriocysts, the subendometrial islands, the fan-shaped striped striations, which kind of look like light through the blinds. You have subendometrial islands, you have translusional vascularity, and junctional, you cannot mark out the endometrium. Okay, sorry about that hitch. So some women have subendometrial lines and buds. As you see in this description, it's very difficult to map out the endometrium. And in this case, you can see a picture showing adenomyosis with the pregnancy of 8 weeks. And this lady, indeed, 1 week later, lost the pregnancy because she has this big subchorionic hemorrhage. Here we see, as I mentioned earlier, adenomyosis for some reason goes for the posterior wall more than the anterior. You have the stripy shadows, and this is typical of the diffuse type of adenomyosis. And if you have lesions of adenomyosis on ultrasound, it is usually very important that you do Doppler. You subject the lesion to Doppler sound, and this is mainly to differentiate between adenomyosis and sometimes the confusing picture of other lesions like fibroids. And it is clear that adenomyotic lesions have what we call the translesional Doppler picture compared to myoma. In fact, in this image, you can see this is adenomyosis, and this is a clear circumscribed lesion of a myoma with a peripheral Doppler, appearance. We use the Musa's criteria in our description of adenomyosis. And in this Musa's criteria, we look at 7 things. As I said, we generally look at, we describe some lesions as direct and other lesions as indirect. The indirect lesions are the uterine size and myometrial thickening. And these are what you would describe in the direct description of adenomyosis. And it's very important that whoever scans a woman with adenomyosis should look out for these lesions. If you get at least 4 or more, most likely it will confirm the diagnosis of adenomyosis. This is a simple running video of adenomyosis, and you can see all the descriptions: the bulky globular uterus and stripy striations. And what I want to say here is that sometimes it is important to use the 3D ultrasound to look out for the endometrial myometrial junction. In this study, they looked at the use of 3D, and to be honest, the conclusion was that there was no improvement in the overall accuracy between a transvaginal ultrasound scan and a 3D and a 2D TVS, depending on the expertise. MRI, yes, MRI has a role in the diagnosis of adenomyosis, and you can see that the sensitivity and the specificity increases by that much, especially if you want to rule out other lesions like endometriosis and fibroids. Of course, there is a very big relationship between fibroids and adenomyosis, and MRI comes out sometimes to delineate these lesions with more accuracy. Hysteroscopy is another way we can look at adenomyosis, and sometimes this is what you would see at hysteroscopy. Strawberry patch, localized vascularization, and endometrial defects. Look out for these lesions when you do hysteroscopy. Sometimes they will guide you to the presence of adenomyosis. That mentioned, it is very important and must say that every time you see a patient with adenomyosis, you always have to look out for endometriosis, because it is rare that adenomyosis will occur in isolation. Sometimes these patients have endometriosis as well. So it would be very good, like when you're scanning, you get a habit of looking into other areas especially the adnexia for ovarian endometriomas. You look out in the posterior compartment for DIE lesions, in the POD, and also the presence of bowel lesions. Just like you see here, in these images, they're trying to show you the different lesions, but sometimes you might get some rare occasions of what they call adenomyomata. Adenomyoma is one of those lesions that can cause severe pain and dysmenorrhea, and you need to look out for it, especially in the young, in the adolescents. What are the take-home messages? I would say that it's important to distinguish between fibroids and adenomyosis, which is also important to remember that sometimes they can coexist. Usually, very distinct and different features can be seen. When you're scanning, try to do both the transabdominal and the transvaginal scan, because the transabdominal is quite good in those women with a bulky uterus, and the TVS will give out, will show you those other associated lesions like endometriosis. A 3D ultrasound can be useful, especially in the assessment of the endometrium and myometrial junctions. And always, when you suspect adenomyosis, please look out for endometriosis. How can adenomyosis cause infertility? Looking at the association of adenomyosis with infertility and the poor obstetric outcomes. So, what is distorted in adenomyosis? Is it the cavity? Yes. Sometimes, especially when you have big lesions, you can get severe discrepancy. For example, you can see in this image that the endometrium is really pushed, and this can significantly affect fertility and pregnancy outcomes. What else is distorted? Vascularity. We know that the vascularity is impaired in adenomyosis, and as I mentioned earlier, that the lesion starts with hyperestrogenism and imbalance in the local hormone melanin, and then we have tissue injury and repair, which will cause hypoxia. And hypoxia generally causes angiogenesis, or the growth of small new blood vessels, which are usually fragile and porous. It is because of this fragility and porous of these small blood vessels that you get bleeding within the myometrium. So every time a woman menstruates, you get those pockets of collection of blood in the myometrium. And this is generally responsible for the bleeding. What else is distorted? We've talked about the cavity. We've talked about the vascularity, but we also know that the partial pressures of carbon dioxide, oxygen, the humidity, and the pH of the uterine environment is really altered by adenomyosis. And the other things that are involved, I wouldn't go much into this, but I just wanted to mention here that you also have what you call the adenomyosis secretome on the endometrium, and others, many other factors. It's really a mixture of factors. It is not a one thing. A high association of upregulation of inflammatory markers and downregulation of markers responsible for desidualization of the endometrium. There are other things that are affected on the uterus, for example, the uterine depth. The uterine depth is affected in adenomyosis because some of these women have a very big uterus with a very large cavity, and then others have a uterus which is very short in depth. We have molecular and endocrine functions, and I want to emphasize a few of these factors. Remember, we all know that the uterus acts like an incubator. For those of you who are interested in fertility and IVF, and the incubator usually has all these factors constant: the partial pressures of oxygen, carbon dioxide, the pH, This is what really adenomyosis affects. So the incubator environment is affected in all those ways I mentioned earlier, and this would explain why women will either not conceive or they will have a miscarriage. I mentioned something about the depth, and in this study of 2013, they compared 8,981 fresh cycles, and that they described that women at extremes of uterine depth, less than 7 centimeters and more than 9 centimeters, were more likely to have live birth. I mentioned this earlier in my presentation, and this is also to emphasize that function, the myometrium and endometrium. An enlarged and distorted uterus is under significant mechanical stress, and that's difficult have impact on fertility and obstetric outcomes. The key message here is that there is convincing evidence from previous studies that adenomyosis impacts fertility negatively. Let's look at the impact of concurrent pathology on adenomyosis. And basically, as I mentioned earlier, that we usually see adenomyosis in association with these other ailments. It doesn't really come alone. It comes with, gets associated with it. And these are commonly fibroids. Those of you who are surgeons and often do surgery will note that most times when you go for myomectomy, you will find adenomyosis associated with them, or the other way around. And as I also mentioned that, when you suspect or when you diagnose adenomyosis, you always have to look out for endometriosis because they are very close cousins. And of course, other endometrial pathology like the endometrial cysts. I've mentioned this, and I just want to emphasize again here that how can we suspect the association? For example, if you see endometriomas or lesions of DIE, you have to assess for what you call the negative sliding sign. A negative sliding sign is when you put in the transverse probe and then you try to move the cervix over the bowel. If you cannot see the uterus moving nicely over the bowel, it means that the pelvis is most likely obliterated. And that is a bad sign on fertility. Most likely women who have an obliterated PUD will also have tubal blockage or endometrioma somewhere, and it impacts heavily on fertility. And also women where you find what you call a question mark sign or the interrogation sign, it means that there is a significant derangement of the cavity. In this study, they looked at the negative sliding sign and its prediction for low outcomes fertility, and it was very clear that it does. The same, this is just an image showing you how the interrogation sign or a uterus with a question mark sign looks. It basically means that there are lesions posteriorly pulling on the fundus. And this is a common thing we see for those who scan patients with adenomyosis or the association with endometriosis. If you look behind here in the POD, sometimes you realize that they have lesions, like there's a lesion here which looks like either a bowel lesion or a lesion around the thorax. And this, basically would show you that this woman has an obliterated POD, and these are women who are going to have poor fertility outcomes. So what is the take home from this? Yes, it is true that adenomyosis associated infertility is a multifactorial thing and is generally associated with other factors. Can we look at the fertility and obstetric outcomes in several studies? This is a famous study. Dr. Sematimba, am I still on?
You are on,
yes.
Doc. You are on. You are on. Please go on.
Thank you very much. So I want to share with you a few publications on this note, and the most famous one is this study which looked at the results after IVF. And you have some publications which looked at the difference in pregnancy rates. The only problem has always been that there is conflicting data. And the reason we have conflicting data is because we don't have enough RCTs. It is very difficult to perform RCTs, and I didn't come across any RCTs talking about this. I think the other reason is the heterogeneity of the ovarian stimulation protocols. I mean, different people have different stimulation protocols, and it's very difficult to come up with something uniform. And also the fact that it's a mixture of the different forms of adenomyosis without a proper description in the type and severity. And this study looked at the outcomes of IVF and ICSI in patients who had adenomyosis. It included about 9 studies from 1,865 women. And it was a big meta-analysis. And particularly what they came up with was there was a 28% reduction in the likelihood of clinical pregnancy at IVF and ICSI in women with adenomyosis. The same with this study, which looked at 375 women after a 3D ultrasound, and they looked at women who underwent IVF and embryo transfer. And they came up with the outcomes of clinical pregnancy. And what came out clearly is that using logistic regression and controlling the confounders, they realized that women who presented with about 4 or more of those sonographic descriptions we talked about earlier are more likely going to have a poor pregnancy outcome. There are recent meta-analysis looking at this association, like there is this one of 2017, which looked at a number of women who had adenomyosis, and what came out clear was there was a negative impact of diffuse adenomyosis, and this was more pronounced on the focal forms. This studies looked at several women who underwent IVF and ICSI. And again, what came out is the significant reduction in the cumulative pregnancy rate. There was a reduction in the live birth rate, and there was an increase in miscarriage rate. There was also an increased risk of preterm delivery. Most women who had adenomyosis or adenomyosis-related surgeries usually were not able to carry pregnancies to term. The small for gestational age, the increased rate of cesarean section rate, and pregnancy-related toxemia, PET, was more likely in those women. I will briefly look at something else a bit interesting here in the medical treatment of infertile patients, where they looked at generation analog treatment and generation antagonist potential. Of course, we all know that the variety of medications suggested for the treatment of adenomyosis. I won't go into each of them, but the issue was that when they looked at studies to look at the benefit of treatment, it came out that not many of those had really any impact on fertility. The only comment was that NSAIDs appeared to be the only medical option that would, showed, it's quite interesting, but that study said NSAIDs were more likely to give you better outcomes. Then there is this, the updated Cochrane review of 2019 that looked at women who again were treated with IVF and ICSI using pretreatment Gynae analog. And it was quite interesting in this study that when they used pretreatment with Gynae, rather when they did fresh embryo transfer without pretreatment with Gynae analogs, the pregnancy rate was about 25%. And with fresh embryo transfer with pretreatment, it increased slightly to 30.5%. But I want you to look at the significant increase in pregnancy rate following pretreatment with Gynae and fresh and frozen embryo transfer. So the conclusion was you would get better outcomes when you do frozen embryo transfer following treatment with Gynae agonists, but not using Gynae agonists before stimulation. I think that was quite significant there. What is the key message out of these studies? The key message was that pre-stimulation with Gynae antagonist does not seem to improve outcome. So if you are going to give Gynae antagonists and you stimulate, you are most likely not going to get better outcomes. But if you use Gynae antagonists before transfer, especially the frozen embryo transfer, then the pregnancy rates went up. Perhaps there were other factors. And also to remember that some of these studies were done in patients with endometriosis. So I would think that we need to look at other studies, perhaps the most ones, to come up with solid conclusions. The last part of my discussion will look at the role of fertility-sparing surgery. And in particular, this is what we call adenomyomectomy. And I want us to discuss the different procedures, especially in particular, I came up with more literature looking at the OSADA procedure. I'll discuss what that means. We all know that there are different surgical options in the treatment of adenomyosis. And some of them are, will involve uterine preservation. Here we have, of course, hysteroscopic resections, adenomyomectomy. HIFU is not very common here with us, but it is also exists using ultrasound in the treatment of adenomyosis. A uterine transplantation is pretty much more of a trial. Those women who do not want to use a surrogate can have a uterine transplant. But there is no data to support this yet, I guess. Then for those women who have completed their families, which is not so much in the scope of this presentation today, can have those other interventions. So the question is, who is the candidate for adenomyomectomy? In this study, they mentioned these patients, especially patients who are refractory to the treatment, medical treatment. If the symptoms were not resolving with medical treatment, then most likely those patients were candidates for adenomyomectomy. Preferably patients with focal adenomyosis, women who are less than 39 years. Obviously, if you have a woman above that, maybe if you're going to use donor eggs, most likely you might not catch many of them. Uterine cavity distortion and women with poor reproductive outcomes, for example, the history of miscarriages. We briefly look at the procedure of adenomyomectomy, but the question is, what guides the decision to do or not to do surgery in women with adenomyosis? And if you really feel that you want to do adenomyomectomy, I think it should be guided by the symptoms. Women who have severe symptoms of pain, like the triad I talked about, evidence of severe anemia, the side effects of medical treatment. Sometimes if it looks more like a fibroid, surgical competence is very important before you make a decision of doing this difficult procedure. For adenomyoma, definitely you will require an excision and fertility wish. In those women who have surgical risk, surgical difficulty, incomplete resections, and other, maybe you would say a no, but you have to really weigh on when and how you want to intervene doing surgery in adenomyosis. But if you decide to do surgery in adenomyosis, these are the few steps I want us to look at briefly. For example, there has to be very good pre-op planning because if you do not plan well, the risk of complications can be high. It doesn't matter whether it is open or laparoscopy. Pre-op or intra-op strategies to reduce blood loss must be discussed. The incision of the uterus, excision of adenomyomata, what depth of myometry am I going to use, the installation, the testing of, cavitary encroachment, closure of the uterine wound, specimen retrieval, if you're doing laparoscopy, and prevention of subsequent adhesion formation are key things. And in this image, it looks at the different ways you do this. Most of the time we use the linear type of repair, but you can, these days, people emphasize the use of layered repairs in adenomyosis to try and reduce on the dead space and increase the strength of the uterus carrying a subsequent pregnancy, especially in women with productive desires. So we shall discuss a little bit about the overlapping techniques of repair as described by Osada. That said, there is really big room for open adenomyomectomy because it is believed that you have better tactile feedback and you're more likely to do a complete excision of the lesions via that route through a small, maybe mini phanestil. So yes, and Osada described most of his techniques and studies doing open adenomyomectomies. How does adenomyomectomy differ from myomectomy? Of course, if you are going to do laparoscopy, we know that it's more difficult than doing a laparotomy technically. There is a challenge in enucleating adenomyosis because they are not clear lesions. There's really unclear demarcation between adenomyosis and fibroids. The endometrial cavity is easily entered, and that can really lead to synechia. There is challenge in hemostasis. It can be significant blood loss, challenge to suture without dead space, bleeding, adhesion formation. And always remember, adenomyosis is commonly associated with endometriosis. So when you have to go in to perform or do these surgeries, you have to have the competence to excise the endometriosis lesions as well. Again, to emphasize these strategies. So the question is, what is better, laparoscopy versus laparotomy? To be honest, the answer to me is I do not know because there are not many studies out there to compare the two. And largely the debate looks at things like competence of the surgeon, the size of uterus, and other confounders like the existence of other ailments like endometriosis. Of course, laparotomy is the preferred route for treating diffuse adenomyosis. The lesion is more likely to have thorough excision, better reconstruction of the defect because you have better control. Laparoscopy sometimes would lead to incompletely repaired muscular defects, and the risks of uterine rupture can be used to treat focal lesions very well. We need to avoid powered instruments, but it's believed that powered instruments will give you better, control blood loss. It is very important that if you're going to do surgery, you have to look at many things, especially how you're going to control bleeding, especially if you're going to do it laparoscopically. People have looked at giving GnRH analogs before. The injection of vasopressin is common, and the intraoperative use of tranexamic acid and other things like misoprostol have been used, plus uterine arterial ligation. The incision, what kind of incision would you want to make? Of course, the rule is you try to make an incision all the way to the endometrium so that you can excise all the adenomyotic tissue in between the serosa and the subendometrium. There is a rule of 0.5 or 1 centimeter on either side. This is a laparoscopic picture showing you how we use traction and counter traction and trying to excise all the adenomyosis away from the endometrium. The installation of either methylene blue, putting a Foley inside the endometrium can be helpful to, enter endometrium. But it's also known that when you are going to do a good job excising adenomyosis, you have to open the cavity and use it as a very good guide. So again, how much do you excise? You have to make sure that you remove as much of the disease, but preserve tissue for repair. I think that is the catch, because if you do not, then you're more likely to get a uterine rupture. And if you do not do maximal cytoreduction, again, you're more likely going to get bad healing because you're repairing disease to disease, and recurrence could be quite common. Which sutures do you use? Most people prefer using the usual sutures, but sometimes if you're going to use laparoscopy, it is better to use the locking suture, what you call the barbed suture or the V-lock. But I want us to spend a little bit of time discussing these new modalities via open and laparoscopy, what you call the flaps. What do the flaps do? They give you good hemostasis, they close the dead space and help you to ensure adequate thickness of uterine wall, because the risk of adenomyosis is you're going to excise too much tissue, and when it comes to repair, you have very little left for repair, and then it is not just enough for the patient to get pregnant, but will they be able to carry pregnancy to term without getting catastrophic ruptures? And that, for me, that is the question. So which technique of tissue closure? We've mentioned that you can do the linear repairs, but it's always better to do the overlapping repairs if you have done good resection, to maximize on the strength of the uterus. They've come up with several methods of flaps in the Osada technique. And there is this, what we call the double breast. Double breast, just like the suit, the way you would, tie the suit. You excite the lesions here, you bring this flap and repair it endometrial, the way you see here, and then you bring this flap over the other. And this is likely to give you at least a stronger repair. Osada described this technique using open surgery. And as you see in the pictorial, in here, you open the uterus all the way to the endometrium, open a window in the endometrium, and put a finger to guide you to do complete excision between the endometrium and the serosa, leaving a centimeter on either side. Then you make the 3 flaps, you repair the flaps in a way that the first flap is repaired on the subendometrium, the next flap goes over the first flap, and the third flap goes over the rest of the flaps. And this is the final outlook of the image of the uterus after repair. So this kind of uterus is more likely to give you a better strength after repair, because remember, you're almost doing a classical on this uterus. So the chances that you are going to excise and leave very thin myometria is high. I will take you through a small video of about 1 minute are looking at the findings at hysteroscopy. And here you can see the different patterns of the strawberry picture, the elevation of endometrium. These will literally give you a clue. And then here, this is how the laparoscopic adenomyomectomy is done using a triple flap method. There has to be a deliberate wish to stop hemostasis by injecting vasopressin. Then we usually avoid electrical gadgets to open the uterus. The use of a harmonic is more friendly because harmonic does not dissipate a lot of heat and does not cause a lot of tissue destruction. Then you make a T on the uterus, what you call an inverted T. This was anterior adenomyosis. Then you would excise the adenomyotic tissue in between the serosa and the endometrium. Take as much as possible, leaving about 1 centimeter on either side. The beauty about laparoscopy is that it will give you a very good image, but you must have a very good skill of dissection and suturing in order to achieve this. Then using a V-lock suture, you oppose the 3 flaps. The first repair is subendometrial. A V-lock is important because it helps you to obliterate the dead space quite easily without trying to knot. And then the second flap goes over the first flap. Dr. Simatiba, can you see this?
Yeah, it's
all right, great.
Looks easy, okay. But trust me, it's not so easy.
Yeah, I agree. So the flap, the second flap goes over the first flap, and you repair it over the serosa of the other side, and you can clearly see it is more of a reinforcement. Then the last flap covers the previous flap. So you have 3 flaps going over each other, trying to improve on the strength of the repair. That's the main thing about the use of flaps, to kill the dead space, but at the same time to improve on the strength of the uterus carrying a pregnancy. So that's the final look of the uterus, and we shall discuss when would you allow this patient to get pregnant, because as I said, the risk of uterine rupture could be quite significant if the suturing is not adequate. And this doesn't matter whether it is done laparoscopically or open. The outcomes could be quite similar. Try to avoid use of energy when you're doing this, because it makes repair worse. Okay, so there is also what you call a 4-petal method. A 4-petal method is where you make 4 flaps, especially on the posterior aspect of the uterus. If you have posterior adenomyosis, like in this patient, you already had some adhesions of bowel, which was removed. And then in this particular case, there was ligation. It's possible to ligate the uterine arteries temporarily, making a window in the broad ligaments, and then pass a suture. Then there's use of harmonic hook try to avoid using monopolar on the uterus as much as possible because it disseminates a lot of heat. And then make the flaps from serosa to the endometrium. And if possible, try to use cold scissors and cut out the adenomyoma and then repair those flaps in the same way. So that's the endometrium. If you're not sure, you can, leave a Foley or pass a dye inside the uterus and then repair the flaps over each other, trying to reinforce. If possible, you try to avoid doing anterior and posterior debulking of the uterus because it is associated, if you're going to debulk both sides, then the risk of uterine rupture is even further augmented. So how do you retrieve? That is very important. You can macerate in bag, you can use a colpotomy, you can, get a mini funnel steel and deliver those tissues. Of course, the risk of adhesion is high. People have talked about using several barriers, but I do not have any experience on these. I really believe good suturing techniques, making sure that you don't expose your sutures, and trying to achieve good hemostasis is the best way of preventing adhesions. What are the postoperative outcomes and implications? In this study, they emphasized the fact that if you look at all these interventions, the unscarred uterus, the risk of rupture was insignificant. A vaginal birth after C-section, the risk of rupture was that. Adenomyomectomy, the risk of rupture goes up to 6% compared to myomectomy, which is 0.2. So there is really, really a big risk of uterine rupture if adenomyomectomy is not done properly. What are the factors in Osada's description? He looked at more than 400 patients, and this is what he advised. Adenomyosis removal method, it's better to use a cord knife and avoid powered instruments. The degree of removal and excision of tissue is really important, and you should look at the uterine muscle defect. The method of reconstruction of the uterus is very important. Postoperative wound infection and postoperative hematoma formation impacts largely on healing. The period of contraception prior to pregnancy, it is important that you give your patient, the patient you've done adenomyomectomy will be followed by you, so that you'll really know the consequences of allowing them to carry pregnancy. But it is also important that you scan these patients at least after 3 months to see how much myometrium you have. And you can scan them again after 6 months to be sure that they do not have a very thin uterine wall. If the thickness of the uterine wall is too small, then you have to answer a patient about the risk of uterine rupture. And of course, the skill of a surgeon is very important. Do not do an adenomyomectomy and you let your patient go in other hands. You really have to give them contraception. You have to explain to them thoroughly the risks of having a rupture during pregnancy. We've heard of ruptures of as early as 24 weeks due to previous adenomyomectomies. So to minimize the risk of uterine rupture, he really emphasized that electrically powered instruments should be avoided because they have a direct causal relationship. This is what he described, and you can see that focal versus diffuse, the outcome was better. You see the mean pregnancy rates, the miscarriage rates was higher in patients who have diffuse adenomyosis. And he also noted that the risk of uterine rupture went all the way up to 17.6% in patients who had diffuse adenomyosis compared to those who had focal adenomyosis. And the preterm birth rate was significantly high. Again, another study looked at 16 patients, and you can see that the pregnancy outcomes were not so much. In this study, they looked at the impact of adenomyomectomy, and it is very good to hear that the reduction of pain, menorrhagia, and uterine significant. I'm about to finish. The effectiveness of laparoscopy via obstetric outcomes were studied, and the postoperative hormones, the use of generous, agonist therapy was emphasized post-surgery, especially for women who desired facility, and you are going to give these generous analogs at least the period of 3 months to 6 months before using any form of intervention. In summary, the diagnosis of adenomyosis should be by TVS or MRI using strict Musa's criteria. Focal adenomyosis is associated with primary infertility and as an independent factor, actually, most of those studies, lower pregnancy rate and the doubling of miscarriage rate was high, even in women who underwent IVF. There was concurrent pathologies in most of the patients seen with adenomyosis, especially fibroids, endometriosis, and polyps. The role of adenomyomectomy is poorly defined with lack of high-quality data. I think more studies need to be done to look at how adenomyomectomy impacts on fertility. Pre-treatment with GnRH agonists before conception is much better before embryo transfer than before treatment or before stimulation. And when indicated, adenomyomectomy may improve symptoms. Pregnancy rates appeared higher among patients with focal compared to those with diffuse, and uterine rupture was reported significant after surgery for diffuse adenomyosis. I want to end here thanking you for your attention. And I also want to advertise this next webinar from ALASU. We'll be looking at the urological complications on minimal access surgery. I know for most of the beginners, most of the obstacles to bigger interventions of advanced surgery is usually the urological complications, whichever you look at it. So mark the date, 24th of April, for our next webinar. Thank you very much for listening. And if you have any questions, please, you can go through the chair or put them in the chat box. Our panel of experts, I'm sure, will be very excited to answer them. Thank you very much.
Well, thank you very much, Dr. Spire, for that presentation. I can't say more. It was such an elaborate presentation. For our colleagues who missed, I can only say sorry. It was a very good presentation. Before we go to questions, I'll give 5 minutes to Dr. Rod and Prof. Yamal to tell us their experience about patients. In their own words, what is your experience about investigating and managing patients with adenomyosis? I'll begin with Dr. Rod. Thank you.
Well, thank you for the presentation. I think it's very well summarized and all of the challenges that we have with adenomyosis. But I think it's a little bit hard to explain exactly how to manage patients in a general fashion. I think that should be highly individualized. And of course, most of those patients will improve with clinical treatments. And the challenge is how to incorporate clinical treatments into the infertility setting. And I'm not sure that we achieved any good solutions in regards to adenomyosis. Probably moving towards more focal adenomyosis, I believe that patients that clinically would present with concerns about the infertility itself, uh, even natural fertility or with multiple IVF failures. I believe if there is a window, an age window, if the patient is young, I think it's possible to consider surgical treatment for focal adenomyosis. However, in my personal experience, I believe that those cases would be very rare. And for diffuse adenomyosis, I'm still very concerned given the numbers that we have around the world with procedures of debulking procedures, that we are still far away on having a conclusion if we are doing more harm than good, especially because most of those patients would be in an age window that would not be allowed for them to to have good fertility outcomes in the long run. So it's a difficult decision. And we all know that this kind of procedure, this kind of surgical procedure is challenging. Few of us would have large experiences on doing them. And in my point of view, I think that would be still an exception to the rule. Maybe the clinical treatments or maybe considering GnRH treatments prior to any other fertility treatments would be a consideration. Even if that's the evidence, it's not that great. I believe the potential for harm would be lower. And of course, we need to understand that delaying treatments are always bad for fertility outcomes, even if they're surgical or clinical. So that's why I believe we don't have a clear view in regards to on what to do, generally speaking, to adenomyosis in the treatment point of view. But I think we can discuss more, and I would like to hear the words from Prof. Amal as well.
Thank you, Doc. But before you go down, please, I know you have taught us a lot about scans and how to identify most of these lesions. But please, before you go down, tell us more about what are some of the commonest lesions that we expect as gynecologists to see as we are scanning for patients with adenomyosis. What are some of these commonest lesions with your experience?
Usually when I'm scanning and I'm concerned about adenomyosis, I would go much more for the direct signs. If you think about the Musa features, I believe they are more important. But my concern nowadays, it's a little bit on the opposite side. I believe we are having a super diagnosis of adenomyosis because our machines are getting better and people are being aware of the Musa features. So what I can find in the usual day-to-day situations here in Brazil is we have several over-diagnosing cases, especially in young women. But if we think about what we are trying to look at scanning-wise, I believe that hyperechogenic islands would be the way to go. And the subendometrial lines and buds, they are usually very easy to see. And the myometrial cysts as well. So when we do see those features and they are quite consistent, even if it's a diffuse or a focal lesion, I believe that would be the one go. Of course, when we do see the indirect changes of the uterus during scanning, it's more like an obvious situation when we do see a bulky globular uterus, and when we do see a significant asymmetry in between the uterine walls. All of those things would just confirm the other more direct signs that we can see. And of course, if we do feel that we can have a focal adenomyosis, it's important to understand the positioning and describe exactly what the position is. And especially if we can see or not see a separation in between the lesion itself and the endometrial cavity. So those are the things that we would be focused on diagnosing adenomyosis with ultrasound, which I believe is the method of choice. Of course, we can see adenomyosis through MRI, but since we are talking about the uterus itself, I don't think we need to go further with MRI in most of the cases. I think ultrasound would be enough.
Oh, thank you, Doc, for that presentation. We shall get back to you. We have so many questions in the chat box. Prof. Jamal, take it on from the question. Is there something like idiopathic dysmenorrhea? Please take it on from there.
It seems that exists the idiopathic dysmenorrhea, and it seems perhaps it is the beginning of the history of adenomyosis, the TR theory. Perhaps, I don't know. No one knows exactly what is the relationship between both. But before beginning, I would like to talk about some things important to keep in mind when dealing with adenomyosis. And Dr. Roda said that surgery should remain something exceptional for managing adenomyosis patients, except for patients that should undergo hysterectomy as final solution after they are completed their family, or for when we found any solution for them. And even when we shall do a hysterectomy, we must highlight for something not aware that if you hide something like the question mark signs or negative sliding signs, pay attention to deep endometriosis, possibly involving the rectum, and the surgery is different from and more challenging from habitual hysterectomy, and should be done with the proper counseling of the patients. And even when we have to deal with the focal adenomyosis, also adenomyomectomy should be attempted only in case of failure of other therapy for patients undergoing fertility treatment or suffering from dysmenorrhea and hemorrhage with no fertility problems, because we had a lot of treatment to propose before going to surgery, because it's challenging surgery, mostly incomplete surgery, even if in a good hands, because as said before, the plans between the normal myometrium and the adenomyosis lesion is not clear. And we have also recurrence. So we can deal with many drugs. Dionagest seems enough effective to be attempted at first-line treatment. But also we have to keep in mind that one of the most important treatment to deal with symptomatic adenomyosis is the levonorgestrel intrauterine system, Mirena. It's really efficient treatment for symptomatic patients to alleviate symptoms, and its efficacy over time, and efficacy can be roughly 70% of alleviating symptoms. So we have to keep in mind this treatment is simple, it's cheap, and it's efficient. So don't forget it. And those medical therapy are also interesting for patients dealing with fertility problem. Because as mentioned before by Spire, implantation is low in case of adenomyosis, clinical pregnancies, miscarriage, or higher, and we can prepare our patient to do that procedures by reducing uterine volume And this reduction of uterine volume and lesion is important for these patients. You can do freeze-all strategies. You can use levonorgestrel before attempting to transfer frozen embryo transfer. You can prepare with long-term treatment, middle-term treatment with GnRH agonist, and it is advised in a very enlarged uterus to try to reach a reduction by half of the uterine size before transferring embryos under hormone replacement therapy. So we have many things to do before surgery to improve symptoms and also to improve fertility outcomes of our patients. Levonorgestrel intrauterine system is a very interesting tool to use. I have one remark about surgery. Very nice demonstration you did, Spire. Excellent, really impressive. But it is advised also when you suture to do some removal of the serosa of the part the part which is overlying the and the internal part of the triple flap to make the adherence between the flaps more strong than if you leave the serosa of the flap. But it was really an interesting and demonstrative surgery. Congratulations.
Thank you, Prof, and thank you, Dr. Spire, for that. We have some questions here. Some of them have been answered in the course of the. But Dr. Spire, this is your question. How long does should the lady take before conception after the adenomyometry? Didn't come out so clear.
Thanks, the panelists, for the descriptions, and you really added value to this. Yes, as I said earlier, that before you of course, it's rightly said that surgery should be the last resort. Not every patient would need surgery. There are many other modalities, as the discussants have said. But when you choose to do surgery, then it has to be for the right reasons. That you have to counsel your patient about the obvious risks of surgery, especially the risk of uterine rupture, or even the risk of synechia, because sometimes the surgery is very difficult and encroaching on the endometrium is very common. So it is also quite common that when you want to do diffuse adenomyosis surgery, you might end up now treating uterine synechia, which is even more difficult than the previous. But if you are to do surgery, it should be really to reduce the volume of the uterus and the impact of this large volume of the uterus on distorting the cavity. And as I presented in one of the slides about the guides of when you would want to do surgery, one is when you have a clear, maybe focal adenomyosis with an adenomyomata. If you have risks, rather, history of miscarriages, if you have overt symptoms like bleeding and refractory pain, that's when perhaps I would wish to do surgery. And if done in the right hands with the right expertise, then it is advised that the patient should be followed up by you, so that you've counseled them properly and advised them that they should do a scan after 3 months to assess for healing and look at the endometrium, and again do a scan at 6 months. There is no clear, really, guideline, I must say, even in literature, to suggest when you would allow the patient to conceive, but at least delaying conception at least after 6 months to 1 year is good for the uterus to acquire enough strength. So that's what I would say about it. Delaying conception is the key.
Dr. Rod, is there a role of uterine embolization in the treatment of adenomyosis?
Can you say it again, Simitiba? Sorry, I couldn't
Is
hear you
there a
very
role
well.
of uterine artery embolization in the treatment of adenomyosis?
Well, for me, I'm not too keen on that sort of treatment. I think I would go much more in line with Prof. Frickley's opinion on that. I believe that would be the exception because when we are thinking about embolization, we are trying to reduce the blood flow in an area that has an abnormal blood flow already. And the effects on that appear not to be that interesting because most of those patients would have other injuries or vascular injuries because of the embolization itself. So it's very hard to think about that kind of treatment for fertility preservation issues. And if we are not in a setting for fertility preservation, if we're thinking about a more definitive treatment, if the patient is not herself moving towards the menopause, and that might be one of the things that would reduce symptoms anyway. She would be a candidate for a more definitive treatment, and that would be hysterectomy. So, in my point of view, I think uterine artery embolization would be selected only for those cases where the surgical risks would be extremely high, and that might be one of the indications. But when we think about the situation for our patients, that would be a very rare occurrence. So we have a big pressure here in Brazil for people trying to do vascular interventionist options. But what we can see in the day-to-day practice, it's not good results. And especially those that are doing those procedures and trying to conceive after the procedures, the situation is more like a disaster. A lot of problems with endometrial cavity, with small endometrial cavities, very stiff, and with multiple attempts of embryo transfer with no results. And so that's, I would let the uterine artery embolization or any embolization whatsoever for uterine lesions as an exception to the rule.
Thank you, Doc. As we summarize this, we have a few minutes to go, but someone asked, what does the developmental IUD significantly reduce the severity of symptoms and the size of adenomyosis? Prof, please take it on.
Can you repeat it, please? I didn't hear it very well. Please talk in the micro. Talk in the micro, please, so I can hear it well.
The levonorgestrel device, does it reduce the size of adenomyosis and the severity of symptoms?
Absolutely, absolutely. You can reduce the size, and the reduction of size is greater than those obtained with contraceptive pills, greater than those obtained with Dionagest, and quite similar to GnRH agonists. And it's well tolerated on long-term use, very well tolerated, much more than GnRH agonists. As you know, we have limited time to use GnRH agonists. You can use ADVAC therapy to reduce the risk of bone loss and symptoms of menopause. And you can combine both. In case of very enlarged uterus, you can use at primary treatment GnRH agonists for 2-3 months to reduce the volume, to reduce the inflammation, to reduce contraction, and so on. You can place the levonorgestrel intrauterine system, and the expulsion rate is lowered by this technique, and efficacy is enhanced with this. And definitely, yes, you reduce symptoms, particularly hemorrhage and also pain.
Okay, thank you, Doc. Then the question is, the other question is, I think this goes to again, Prof. The comment on some patients with endometriosis lesions close to the myometrial junction that present with intermenstrual bleeding or prolonged periods, which can be dark, old blood, and have less dysmenorrhea. I think he meant a subtype of those patients with prolonged periods and intermenstrual bleeding. What really causes intermenstrual bleeding and prolonged periods in these patients with adenomyosis? Prof.
What caused the bleeding?
Prolonged periods and intermenstrual bleeding.
I don't understand the question. Please, can you simplify it?
And I think I'm going to open up to Dr. Gideon to elaborate on your question. Dr. Gideon, are you there?
Yes, Dr. Matimba. No, it was just a comment that I've seen some patients who have adenomyosis and also will present with prolonged or intermenstrual bleeding. It may, and usually it's a dark blood, and when you do evaluate the scan or MRI, you note that there are lesions. Then the adenomyotic lesions, although are closer to the endometrial-myometrial junction, so they tend to bleed and seep through the endometrial cavity, and after the periods, they tend to continuously have some old blood seep.
Yes. Yes, and I understand what you say. It is normal
from those lesions
in this condition.
Out of the endometrial cavity. They may not present with a lot of pain.
Yeah.
Yes, Prof.
Yes, yes, it's normal to have such condition because, as you know, the contractility of the uterus is abnormal, and sometimes the myometrium is rigid, and it can't expulse all the blood within the period, and this blood remain in the cavity, and you can see it sometimes. You see fluid in the cavity for a patient with adenomyosis, and this is old blood, and this blood is progressively it becomes black. So it's not a problem. It is similar to any bleeding, and you treat it similar to other kind of hemorrhage.
Oh, thank you. As we close, Dr. Rod, I think this is a question that someone has sent to my inbox. Is the exclamation or question mark sign a sign of adenomyosis or endometriosis? Then what would you prefer to measure the endometrial junction? Is the MRI or scan? Dr. Rod?
Well, the first question is the question mark, which is an antiverted and retroflexed uterus. It's much more associated with endometriosis. So we would have posterior compartment endometriosis when we do have the complex of the uterosacral ligaments, torus, and usually towards a bowel lesion, we would have that kind of presentation. So it's much more associated with endometriosis than with adenomyosis specifically. Well, of course, those things would happen frequently together, but it's much more associated with endometriosis. And when we are evaluating the endometrial-myometrial junction, what we are trying to look at are other signs of adenomyosis, especially when we are thinking about interrupted or non-visible or irregular endometrial-myometrial junctions in the attempt to find the features of adenomyosis to make a diagnosis. And the performance of the ultrasound and the MRI are very similar in those cases. So I don't think MRI would add anything different into that perspective. So I don't think that MRI would be useful in that sense, since it's harder to have access. It's more expensive. So I don't see a point on adding MRI just for that feature specifically.
Thank you very much, Dr. Rod and Dr. Professor Amal for the comprehensive discussion. At this juncture, I want to call upon Dr. Spire, who is the president of Association of Laparoscopic Surgeons of Uganda, to give the closing remarks in the interest of time.
Thanks, Dr. Sematimba. And before I give my remarks, I wanted to request the fertility specialists working locally, especially I saw Dr. Mark Muyingo, Dr. Businje on the platform. Dr. Mark and colleagues, if you're online, would you want to give one or two comments in your practice of fertility treatment? What is your experience of dealing with adenomyosis patients? I just wanted to know the local perspective. I don't know if any of them would want to give us a comment before we close.
Thank you very much, Dr. Spire. I don't know whether I'm audible.
Yes,
this is Dr. Muyingo Mark. This is Dr. Muyingo Mark. Yeah, adenomyosis is, good evening, colleagues. Adenomyosis is one of those conditions that give us a lot of challenges, especially in our fertility management. But basically what we do at our facility, we have been using GnRH analogs. Of course, when we do our stimulation, we will do a freeze-all and use GnRH analogs for at least a minimum of 3 months before we plan for a frozen embryo transfer, especially for those that are focal. But diffuse is one of those that has been giving us challenges. But I'm glad to learn that the levonorgestrel IUD also gives similar results. And it's something that I'm very much willing to give a try on for those people who have adenomyosis. But definitely it's one of those that challenge us quite significantly. And in some instances, we might have to opt for surrogacy for some of these patients. Thank you.
Thank you, Doc. We are always great to have you. You have taught us most of these things you're practicing. Dr. Businje, are you there?
It is very a good comment that he gave. I was about to ask, when do you say that I've given up on this uterus and I have to go for a surrogate? That was my open question to any of the panelists. Is there a point you reach and you feel that this woman would not be able to use the uterus? I don't know.
Really, when we fail to obtain a pregnancy after using all that tricks and tips in patients with adenomyosis, we are really facing a very difficult condition. In my country, it is not allowed. It is forbidden to have surrogacy for such cases, so they can go out border to search for this kind of solution.
Okay, yeah, because it's a bit tricky.
And in my opinion, I think I would pass that ball to the patient. I think when she is already tired of all those attempts, if she's really tired of that and she does have the potential to have good embryos, then that's the time when it's her time, and then she would bring that up herself. Also, it's time to try another uterus because things are not moving. So that's a ball that we usually pass to the patient, and most of the times it's successful. Right?
Yes. Thank you very much for all the panelists for taking time out to give us your expertise. We've learned a lot out of this. Thank you very much. We do appreciate for everyone who has spared time to stay this late. The Association of Laparoscopic Surgeons of Uganda will organize many more of such to allow us share experiences and see how things are done on the other side of the world. I want to thank you for chairing the meeting, and I want to hand over to you. Thank you. Good evening, everyone.
Good evening. We wish everyone a safe stay. May God bless you. Meeting is closed.
Bye. Bye, everyone.
Thank you. Thank you very much. See you.
Bye.
Nice to be with you.
Bye.